it's a very interesting session, and this is also a very interesting question. The reason being is there's no right or wrong answer to this. Clearly, in some cases, we need to think of a second or a third clip up front. But in other cases, one clip can do the job. Now, are there any hard rules to predict that? That's very difficult to tell. I have to say that when we started the MitraClip journey about 5-6 years ago, or even more, we were told by our trainers that we should be aiming for a 50% reduction of the mitral regurgitation at 2+ MR or below. And that actually was what we intended in the first initial 10-20 cases. But as the technique evolved and the clips became better, and our understanding of the predictors of mid and long-term success were made clear by the registries and the trials, we started to aim for a 0 MR. Now, 0 MR is a very ambitious target. We know from the surgical era, especially from functional mitral regurgitation, that 0 MR is a holy grail, you cannot get it. But surely if you aim for a 0 MR, you may get a better result. And now this is when the number of clips has started to go up. Now this is a case, here is a functional mitral regurgitation. You can see that the leaflets are being tethered and pulled inside the ventricle, and there's a central jet of significant mitral regurgitation. Now we go to the commissural view. Clearly we can see that there is a jet, which is mainly in the medial part of the valve. Here is the lateral commissure, is spared. The medial part is more pulled because this patient has got an inferior myocardial infarction, and this is very clearly seen on the X-plane. So one can think that if I put a MitraClip there, which we did, straight in the middle of the jet, we can do the job. And actually this job is done. There's another narrow jet on the lateral part. Here we decided to leave this. And it was a successful case with one clip. Now, this is another case. This is a more balanced situation. Commissural view, central mitral regurgitation, two jets that collide with each other. You see they combine. So actually there's one broad jet, much broader than the previous one. So that might be a predictor. Clearly in the X-plane, we can see that there's a severe mitral regurgitation. This is the effect of one clip. This clip is put medially on this jet, and we can see that he's already reducing the width of the jet. So the medial part of the jet is becoming narrow, almost gone, and there is a significant lateral part. Now this is possibly a 2+ MR. Maybe some would argue it's a 3+ MR, but clearly we would not accept this as a final result. So here is a second clip, which is put just lateral to the first one and clearly reducing the lateral part of the jet. And now we can see two clips, body clips, parallel to each other, creating this three-dimensional image. So I think nobody would argue that this is a situation that two clips are necessary. And here is another case, which is even worse. Now, total remodeling of the mitral apparatus, dilated atrium, dilated annulus. The leaflets are horizontal. There's a horrible mitral regurgitation. This is a commissural view again. So this is not only 1, 2, 3 jets or one huge jet with a vena contracta over 1 centimeter on the commissural. This is the long axis. And practically you can see that the leaflets are not coapting. So you know up front that this cannot be fixed by one clip. Maybe 2 clips will not be enough. 3 clips may be necessary. So this is the 3D. You can see that the leaflets are not touching each other. This is the first clip. Our intention is always to put the first clip medial and then work ourselves from medial to lateral because it's intuitively easier. You put one clip closer to the septum and then your second clip goes beyond it and beyond. But sometimes you cannot grasp medially, so you grasp where you can. And this is lateral. So the first clip is lateral. Lateral jet is gone, but there's a medial jet there. So second clip goes just medial to that, reducing further the central jet, but there's still a medial jet. Third clip goes further medially, creating a very nice result. There is still another jet medially. I can tell you this patient was very good because his LA pressure was up to 95, the V wave went down to 35. This tiny medial jet, 1 year later, this was an intubated patient by the way, became significant. So there was a 2+ MR from this tiny medial jet. So one could have thought to have put even a 4th clip in this medial jet. But I think we did good for this patient, and it was okay. It was an acceptable result that actually saved his life. This is the final result. So, but sometimes you have to think, because this is the beauty of this procedure. This is a procedure on a beating heart, on full hemodynamic loading. This is a patient with functional mitral regurgitation, atrial fibrillation. You can see on this commissural view, there's a broad jet. Okay, it's 1 clip, 2 clip. We put the first clip. Wonderful result. Look at that. We're happy. We can go. This is a 20 minutes procedure. But look at the blood pressure. Blood pressure is 90/50. So we increase the blood pressure to 105. You can see that there's a further jet arising from the medial aspect of the valve, which shows that you have to sometimes challenge the afterload of these patients. So you have to put a second clip on this one. So we put a second clip, and that's it. With a blood pressure of 120, 130, mitral regurgitation is gone. So we can predict the outcome based on the hemodynamic loading of this patient. And sometimes we have to challenge that on the table to make a decision. But sometimes you have unpredictable things happening. This is another ischemic patient with functional mitral regurgitation. This is actually a reshaped patient. We put 1 clip straight in the middle of the jet. Look what happens to the left atrium. There's clouds there. Clearly, the valve is not opening. This is the commissural view. And the mean gradient went up to 13. Blood pressure went down. Forward flow went down. So clearly this patient had developed severe mitral stenosis acutely. So we opened up the MitraClip and we thought, okay, let's move this clip as far laterally as possible, because we saw on the 3D that the medial commissure was opening okay, and the lateral commissure was fused, so there was a hidden rheumatic disease there. So when we put that, we had an acceptable result in terms of reducing mitral regurgitation. We still had a lot of spontaneous echo contrast. That is something we expect because we reduced the backflow of the mitral, but we had an acceptable gradient. And this patient is now almost 3 years out, and he's doing very well. So, you know, there's no easy way to predict this. You see a broad jet, you say, okay, I'm going to put 2 clips because we need 2 clips. You put 1 clip and you have stenosis, so you have to deal with that. And sometimes, you know, you have to look at the commissures, because when you put a clip in the middle, the opening of the valve relies on the commissures, and that's sometimes very difficult to see up front. This is exactly this patient. You can see this medial commissure is opening, the lateral commissure not that well. So this is a clip that was put towards the lateral commissure, leaving the medial commissure relatively free to open with an acceptable result. Now, when it comes to degenerative mitral regurgitation, it becomes even more complicated. Look at this situation. This is a narrow scallop of a Flail P2 there, with some basal annular calcification. Actually, the calcium you can see. So this is the reason. This is an 86, I think, year-old female patient, and you know, high risk for surgery. So we thought, okay, we have 1 shot here. We have to put the clip straight where the flail part is. And this is what we did, and this is an acceptable result, as you can see, with almost no mitral regurgitation, with a mean gradient of 2. Now, this is not always easy to achieve, and sometimes you may not be able to be accurate when you put the clip, but you have to try. Clearly, this is a situation that the second clip is out of the question, because there's limited space and the calcium is your enemy here. Here is another case. This is a truly flail valve. You can see with the vena, with the Pisa here on the long axis, that this is a severe mitral regurgitation, and actually the whole medial commissure here is totally ripped apart. You can see that there is a lot of flail tissue. The first clip goes straight on the commissure. You can see this is the septum, this is the clip, and you can see that the clip actually goes on the commissure, and then a second clip follows next to that. And by that, you actually can stitch practically the commissure. So you create a unicommissural valve. You only have 1 commissure left to open. And you can see some remnants of the cords there from the medial part of the valve. 2 clips were enough on this patient, and this is usually the case when you are treating commissural prolapses, because the tissue there is shorter and there's not excessive tissue in the A1P1 or A3P3 area. Usually 1 or 2 clips can actually deliver what you need, like this case, for example, with the prolapse of A2, A3, and pretty much you can predict on this patient that 2 clips will be necessary. So by putting the 2 clips in a V-wave fashion, like that, you can create a valve with 3 openings, 1 laterally, 1 medially, and 1 in between the clips. Now, we have the XTR now. The XTR is a bigger clip. It adds another 5 millimeters of extra length, of grasping length, when you open the clip in the grasping position in the 120 degrees. And that gives you an extra material, if you like, to grasp more tissue when it comes to big valves. Usually big prolapses with excess tissue, but also functional mitrals with big annuli and long leaflets. This is a case that we did recently, a patient with a Flail P2, long leaflet. You can see it's a very long leaflet, but long is one aspect of the problem. There are 2 more aspects: the width, the height of the prolapse, and also how far back the prolapse goes into the annulus, because the lack of secondary chordal support is also pivotal. This you can see on the long axis. The tip is flail, clearly, but you can see that the leaflet is unsupported by secondary cords all the way back to the annulus. So that's a problem. So by putting an XTR here, you can actually pull more tissue to the coaptation with the anterior leaflet. Also, we measured the length here, the prolapsing width, that was 2.3 centimeters. So we started zipping this valve, this P2, by putting 1 XTR that we managed to actually grasp lateral here. Medial was not easy. Then we put a second one just medial to that, as you can see, as a body clip, and we had an acceptable result. But when we looked into the 3D, we didn't like the fact that there was still some residual tissue, even more medially. It doesn't show very well on this. We had an acceptable color, but we decided to go further and just grasp this additional prolapsing part there. And we had a really very, very good result with this whiff remaining. And look at the 3D. We had a very good result. Now, you have to fix the anatomy, and here is what the flail width looked before and what it looks now. Clearly, you only have the commissures left, and this is totally stuck together with the anterior leaflet. So I hope with this example, I was able to illustrate some technical aspects of how we can make decision about the number of the clips we can use for the cases. There are no hard rules. The aim, of course, is to get an optimum result. Plus 2 MR or below is the traditional teaching, but I can tell you that we're aiming for 0 MR. The aim is definitely to reduce the MR in the functional patients, but to correct the anatomy, if possible, in the degenerative patients to prevent recurrences of the mitral regurgitation. Of course, technical accuracy is important. The clips have to be parallel. You can make sure of that by using various tips and tricks. Fluoroscopy also can play a big role on that. We need to make sure we don't distort the anatomy, we don't create a torsion, a spaghetti effect on the leaflets. And of course, it's important not to create stenosis for these patients. Thank you very much for your attention.
Any comments? From the studies, the French study and the QAPT, they had to put more than 1 clip in a big number of cases. Seems like only half of the patients, 60% probably, they did well with 1 clip only. 24–25% they needed a second clip, and I think it was 9 or 10% the patients they needed a third clip. And I noticed you're not saying anything here about the 4th clip, and I don't know if anybody has put the 4th one. How far you go to the commissure with a clip? Do you avoid the commissures? You go close to the for us as surgeons, we don't like leaks around the commissures. It's very difficult to fix them. We have to reposition the whole head of of the papillary muscle towards the apex, and we have to do a lot of tricks to get that, and sometimes we're not able to fix the leak if we have leak there in the commissure. That's the second thing. And I think 2+ leak is a lot of leak. It's not acceptable for us.
Okay. First, let me answer the first question. It depends on whether you touch the commissure or not, depends on the pathology of the valve. If it's a truly functional mitral with tenting and tethering of the leaflets, usually the jet tends to be central, A2, P2 area, usually. So you don't have to touch the commissure in this situation. Occasionally, we had cases with posterior myocardial infarction, aneurysms, fibrosis of the papillary muscle. We had extreme tenting of the P2 and the P3 area, and sometimes you have to go as medially as possible, but it tends to be technically quite demanding and difficult because the posterior leaflet is short, the angulations are different, and there's always a risk to get tangled in the subvalvular apparatus. You don't want to get into the fan of the cords from the papillary muscle, and then you can get trapped. So you have to be extra careful how far deep you go into the ventricle and some other technical aspects. When it comes to prolapsing, of course, we're talking about high risk surgical patients, high surgical risk. This patient that I showed was a rescue case. It was a patient intubated with severe kyphoscoliosis, paraplegic patient from old polio, and we had to do something about him. He was actually dying. So it's surprising that we did, I don't know, maybe Kostas can share his experience. We haven't done that many commissural cases, but we never had relapses on these commissural cases. The relapses we had on the DMR patients were when we were dealing with excess tissue in the center of the valve, and we didn't deal with this excess tissue from the first procedure. So by having redundant tissue at the edge of the clips, there was the cases that we had relapses. In the commissures, usually it's a limited space. You catch it and you're done. It's technically more difficult, but if you catch it, we had good results. Of course, we have small numbers. We don't have thousands. We have a few, it's a smaller number. So what was the third question about the last case you said? I didn't understand.
About this 2+ regurgitation, which is not surgically acceptable.
No, for DMR is not surgically acceptable, yes. But, the 70% of the cases are functional mitral regurgitation. As I said before, we were aiming a severe functional mitral to reduce it by 50%, 2+ MR or below was what we were aiming for at the beginning. Now we're aiming with 0 MR, and this is something that has changed globally, I think.
Just a comment about the number of clips in COAPT was 1.6, the average, 1.6 clips per patient, which means that approximately 60% of the patients would need 2. And I think it was 35% just 1. And they attained these results with this number of clips. And remember that these were only FMR patients, and usually in the DMR patients we put more clips than the FMR. So they got the results they got in COAPT with this number of clips, so for the time being we have to follow these general rules. But as we heard earlier today from Francesco, there are some probably new things coming up to guide us, like hemodynamic monitoring, continuous hemodynamic monitoring, which we have started using already, but we don't know exactly how to incorporate it into our algorithm on uses of a second or a third clip. And finally, we have a new system, the Pascal, that is much wider, and you can get the MR you get usually with 2 clips by using just 1 Pascal. And this, I think, will be a big advantage for many patients that will get out with 1 device implantation instead of 2. And the MitraClip is also coming next year, I believe, with the wider device, 7.5 millimeters. So everything moves there because it's always safer and quicker to finish a procedure with 1 device instead of 2. There is this 1 or 2% of cases that you go in with the second clip, the second device, and instead of doing better, you're doing worse.
Okay, thank you very much. Thank you, Dr. Ninios.